Every beat of the heart sends a shock wave through the body, exerting immense mechanical pressure against the inner walls of the arteries. In a healthy, unburdened vascular system, those walls easily absorb the force. The baseline metric for this normal state is a reading of 120/80 millimeters of mercury. This animated diagram illustrates the clinical threshold for danger. On the right, arterial pressure is elevated to 140/90 or higher. This is hypertension. The heart is forced to work harder, and relentless turbulence inflicts continuous structural damage to the blood vessels. The danger of this condition lies in a biological paradox. This violent mechanical overload happens deep within the body, completely bypassing our pain receptors. That total lack of warning is exactly why it earned the title of the silent killer. Because of this internal silence, roughly 90% of patients carrying this lethal pressure load walk around entirely asymptomatic. They feel perfectly fine. When visible symptoms finally do manifest, it is a warning that the vascular damage is already advanced. The common late-stage indicators of this internal strain include severe morning headaches, dizziness and constant fatigue, blurred vision, and frequent nosebleeds. A severe crisis-level spike in pressure escalates the situation rapidly, resulting in acute chest pain, shortness of breath, and sudden confusion. Relying on a patient to feel their blood pressure is a fatal clinical error. Surviving hypertension requires aggressive diagnostic interception long before the patient realizes their system is failing. What specific structural or chemical anomaly causes arterial pressure to lock itself above that 140/90 threshold in the first place? The clinical answer usually falls into the dominant category, primary or essential hypertension. This branching clinical tree shows that primary hypertension accounts for 90 to 95% of all cases. It develops gradually over years, lacking one single easily identifiable cause. The remaining 5 to 10% fall into the secondary branch. These cases are driven by a specific underlying pathology, such as advanced kidney disease or endocrine disorders that disrupt the body's fragile fluid balance. Certain external medications can also act as pharmacological triggers, artificially driving up vascular resistance. The first major target is the kidneys. Laboratory tests, specifically urine examinations, look for proteinuria, the presence of excess protein. This is a direct warning that mechanical pressure has physically broken the renal filtration barrier. Next, the diagnostic focus shifts directly to the pump itself, the heart. An electrocardiogram, or echocardiography, is deployed to check if the heart muscle has structurally enlarged or sustained damage while fighting the constant vascular resistance. The final, and perhaps most direct diagnostic window into the body's vascular health is through the eyes. During a fundoscopy examination, doctors look straight at the retina to spot microhemorrhages and other direct retinal damage caused by systemic pressure. This diagnostic protocol serves as a systemic audit, confirming that silent pressure is actively dismantling the body's vital infrastructure. How do we actively force that pressure back down below the 140/90 threshold? The first line of defense relies entirely on lifestyle modifications. The initial goal is fluid volume reduction. Limiting the patient to less than 5 grams of salt per day stops water retention, pulling excess fluid out of the pipes. Then comes mechanical system optimization, demanding at least 30 minutes of regular exercise daily, and strictly maintaining a healthy weight to reduce the physical burden on the heart. Finally, chemical vasoconstrictors must be removed. This requires the absolute avoidance of smoking, strictly limiting alcohol, and managing stress to prevent the vessels from constantly clamping shut. These lifestyle shifts function as rigorous mechanical interventions, engineered specifically to reduce the physical load on the vascular walls. When those mechanical lifestyle changes fail to move the needle, we must introduce pharmacological management. This flowchart illustrates the 5 common drug classes used to artificially manipulate the cardiovascular system. Diuretics, like hydrochlorothiazide, target the kidneys to flush out excess fluid, physically lowering the volume of blood in the system. Vessel relaxers, including ACE inhibitors, ARBs, and calcium channel blockers like amlodipine, chemically force the arterial walls to widen, drastically reducing resistance. Beta blockers, such as atenolol, target the heart directly. They slow it down to reduce the raw output of pressure. Managing this complex matrix of drugs is the primary focus of nursing management, demanding regular blood pressure monitoring, rigorous patient education, and strict medication adherence. These medications act as chemical overrides that hijack the body's systems to prevent the pipes from bursting, a process requiring absolute patient discipline. What is the inevitable outcome if a patient ignores the warning signs and abandons their management protocol? The pump fails. Exhausted from years of pumping against massive resistance, the heart eventually suffers a myocardial infarction or outright heart failure. Then, the delicate cerebral vessels in the brain shatter under the sustained pressure, resulting in a stroke. The microvascular networks in the eyes and kidneys are systematically obliterated, guaranteeing vision loss and total kidney failure. Untreated hypertension guarantees catastrophic systemic collapse because it aggressively targets the exact infrastructure every single organ relies upon to survive. We once treated this condition as a street corner novelty, charging 25 cents for a casual reading. The modern clinical approach is vastly different. Find the anomaly early, hunt for proteinuria and retinal damage, and intervene aggressively. Survival requires unyielding adherence to both mechanical lifestyle adjustments and complex pharmacology. Hypertension is undeniably a silent killer, but with precise diagnostics and disciplined medical management, it is a killer we can trap, track, and completely neutralize.